Hello and welcome back. So we just got done covering all of the mechanisms of actions of how antibiotics work to destroy pathogens, mainly bacteria, but we hit on some viruses and fungus in there as well. Now we're going to take a look at how the effects are on humans. So how well do we know, how well these drugs are working? So this is what we call efficacy, is the measure or the determination of how well something works. How efficient is it at doing what it's supposed to do? So in this, we're going to talk about some tests that researchers can use to try to figure out the potency or the strength of a drug that's needed to actually inhibit or kill bacteria. We'll take a look at some of the routes of administration. How do we get the antibiotic into the body? And maybe some side effects. Okay, the first thing we're going to talk about is what's called spectrum of action. So this is the idea of how big is your target. So if you have a drug that kills a particular microbe, does it kill all microbes? Does it kill just a very specific type of microbe? And why is that important? So we have what's called broad spectrum and narrow spectrum. So broad spectrum antibiotics or antimicrobials can kill a wider variety of targets. So for example, these sulfonylamides down here, tetracycline, zerothromycin, they're spanning their target into 3, even 4 different groups of organisms. So gram negatives, gram positives, a small little group called chlamydias and rickettsias, and even sulfonylamides can go into eukaryotic targets of protozoa. So those would be considered our broad spectrum. Penicillin, a little bit because it does gram positive and both gram negative. But for example, polymyxin is a narrow spectrum agent, can really only affect gram negative bacteria. It doesn't really have any role to play on gram positives or protozoa or fungi or viruses. So broad spectrum, narrow spectrum. So if you're a clinician, a doctor or a physician's assistant or somebody who has got prescribing abilities, how do you know which one to give your patient? Well, it depends on the scenario a lot of times. If you are coming in and there's a life-threatening infection and you need to act quick, you're probably going to want to do something more broad spectrum to kind of cover the bases of, because you don't know what the organism is yet. And then once you get your sample sent off to the lab and they come back and you're like, oh, it's a gram negative, then you might be able to narrow your focus a little bit and target that particular thing. If you have some time to wait, it's always better to figure out what your organism is and then get a targeted drug specific for that, more narrow spectrum, because one of the side effects we haven't talked about yet, because we'll get to that next, is this selective toxicity that we've been focusing on, targeting the bacteria. That's great. It doesn't affect eukaryotic cells, but we have more bacterial cells as part of our normal microbiota than we actually have human cells. We are more microbe than we are human. Kind of a weird thing to think about. And we have normal microbiota that keep us healthy. We have it on our skin, we have it in our respiratory tract, our digestive tract, our reproductive tracts. So when we take these broad spectrum antibiotics, or even the narrow spectrum, they not only target the pathogen, which is good, that's what we want, but they also target our normal bacteria, which could give us even more varied side effects because now it's throwing off our homeostasis of our natural systems. So the more you can focus in on your treatment, the less negative outcomes for the patient that you will have. So that's our discussion of spectrum of action. The next test we're going to take a look at is what's called the Kirby-Bauer or disc diffusion susceptibility test. So this is when we talk about sending the patient sample off to the lab and getting a result back as to what drugs work best on it. This is kind of what they're doing, or modification of this. This is what we'll be doing in lab, is you take your pathogen, whatever they culture out of the wound or the infection or whatever, they spread it out on a plate. So you can see the growth was what's called a lawn, completely growth all over the plate. And then they put these little paper discs that have been impregnated with a particular concentration of different antibiotics. They just kind of stamp those right onto the top or place those right onto the top of the growth. They let it incubate, right? So they put the little discs on there right after they've inoculated it with the bacteria. Then they let it incubate in the presence of the bacteria or the antibiotic. And the drug in the paper disc kind of diffuses away from the disc and it kind of makes this concentrated circle of drug. And if that drug is effective at killing the bacteria, you get this zone of inhibition, kind of like what Alexander Fleming saw with his penicillin, is it was effective at killing that particular bacteria. So in this example here, we have, these would be the zones. You'd measure it from edge to edge all the way across, and you'd report that in millimeters, and there's a table, and it tells you whether it's susceptible, resistant, or intermediate. So here we have some, probably the larger the zone, the more susceptible the bacteria is to that particular antibiotic. So that those might be good choices if you're going to be prescribing something. If we'll see, disc 5, 7, and 2, not so much. The bacteria grew right up to those paper discs. So the drug is there. They just didn't react to that. So those would be resistant. You would not want to use those drugs because it would have nothing to do against the pathogen you are interested in. And then here, so you might have some intermediates, kind of in between susceptible and resistant, but those are the ones that could turn resistant if exposed to enough of the drug. It's this natural selection, a selection for resistance that we'll talk about in our resistant to antibiotics discussion here in another video. So this is a Kirby-Bauer assay. It is telling you which drugs your particular pathogen are susceptible or resistant to. So this is the information that doctors need from the microbiology lab to make good medical choices as to which antibiotic should be prescribed to their patient. All right, in this next test, this is called the minimum inhibitory concentration, or MIC test. In the MIC test, they are trying to figure out what concentration of the drug works best to inhibit the growth of the bacteria, not necessarily kill it, but just to inhibit it. So on this picture here, we have, I'm guessing tetracycline, because that's the one label I can see here. And then they have concentration. So in this first tube, it's probably just no drug. So it's just the culture. So all of the culture tubes were cultured with the same amount of bacteria at the start. And then they start putting in increasing concentrations of the drug. So here we have 0.2 micrograms, 0.4, 0.8, 1.6, 3 point something, 6.3, 12.5, and then up to 50. I can't see what this one is. But as you can see, it almost pretty much doubles every time. And then they incubate them. Everybody's going in the incubator at the same time they come out. And you'll notice these first 3 tubes had bacteria growing in them. And so no tetracycline, 0.2, 0.4, and 0.8 micrograms of tetracycline in that tube was not enough to inhibit the growth of the bacteria, but from 1.6 on, it does. So you might be asking yourself, well, why would they need to know this information? Why can't they just give everybody 50 micrograms of the drug? Well, if you can get bacterial inhibition at 1.6 micrograms of the drug, what's the point of giving a patient 50? It's a waste of medicine, and it could, the higher concentrations of the drug could have more negative consequences for the patient. So we're trying to not only get the best concentration that's going to work, not just completely obliterate everything, but we want to kind of find the sweet spot, if you will, of efficacy and being efficient with your supplies and with your administration. So that's just inhibition, though. We don't know. These could be bacteria that are just inhibited, but they're not killed. It's not a bactericidal test. That's the next one. Well, the next one. I forgot about the E-test. So the E-test is kind of like a combination of the Kirby-Bauer and the inhibitory test. So instead of doing individual circles of drug, they do a strip that's been impregnated by the drug with a gradient of concentration. So for this particular drug, I don't know which one it is, but here we have really low concentrations, and here we have really high concentrations, so 0.016 all the way up to 256, whatever the unit is, I'm not familiar with. Then they place it on a lawn of bacteria, let it incubate, and so here's our zone of inhibition. So we can clearly see it's bigger around that higher concentration, and all the way down, it looks like right around 0.75, this is going to be our minimum inhibitory concentration. So we can see the efficacy of the susceptibility, and then where that susceptibility drops off with the concentration of the drug. So it's kind of like a 2 tests in 1. For the minimum bactericidal concentration test, what you would do, you'd have to do the MIC test first. So you'd have to do your minimum inhibitory concentration test, and those first 3 tubes that didn't show any growth, that's what these are. These are the first 3 tubes. So it's not the same from our example, but let's say This had 8 micrograms, 16 micrograms, and 25 micrograms in the MIC test, and they were all clear. So then what they would do is they would take a swab or a loop full of the bacteria and grow it out on a plate and see, did those concentrations actually kill the bacteria or did they just inhibit it? So in this particular test, we can see that 8 micrograms per mil of drug in that culture didn't kill the bacteria, it just inhibited them. So that may not, if we want bactericidal, we know we need something a little bit stronger than the 8 micrograms. The 16 micrograms shows that yes, they were dead, also the 25. So in this case, this was our sweet spot, right? We found that at 16 micrograms per mil, we inhibited it and killed it, right? So that's kind of how we can, narrowing down the focus of what our goals are. Okay. All right, the next thing to consider when giving antimicrobial drugs is how are we going to give that to the patient? And there's some benefits and drawbacks, right? So pros and cons to each one of these methods. So these graphs are showing you blood concentration. So what is the relative concentration of drug in the blood over a couple hours time? So like 2.5 hours or something. Now the first one is oral, so that's just like taking a pill. Couple times a day maybe, right? So you have your regimen, so here's your pills, take 3 times a day, 2 times a day, once a day for 5, 7, 10 days, whatever the regimen is. Now with oral administration, you can see it doesn't get very high into the blood. So what would, that's not that great. So what would be a benefit of taking or administering drugs in the oral route? Well, it's easy. Most people can take medicine. It's cheap. You can do it at home, right? So there's some good things about that. It's easy and it's cheap, right? And when you're healthcare, that's what you're kind of looking for. The downside is, like we can see in the graph, it doesn't have a very high concentration in the blood, so you have to maybe do multiple doses throughout the day. Another drawback is you're having to trust patients to follow directions and take their medicine on time for the prescribed length of time. So those can be some pretty big downsides as well. So again, you're trying to figure out what is the best route for that particular patient for whatever condition they're dealing with. The second example is intramuscular. So this would be an injection of the antibiotic directly into a muscle, either the deltoid or the glutes, or usually a big muscle group. So we can see real quick, you have a nice peak of the drug in the bloodstream because your muscle is very vascular, it diffuses very quickly into your bloodstream, but then it kind of tapers off pretty quickly. So the benefit of this is you get high levels of drug, but there's some downsides, right? It hurts. For me, that was kind of my first thing. I don't want to have to be poked with a needle, but usually you'd have to have a professional do that. Some patients, if they have to do it regularly, they might be able to feel comfortable injecting themselves, but most people do not have that comfort level with self-injection. So you might have to go to a doctor's office, which is going to increase cost, scheduling, and then it kind of fades relatively quickly for that particular example. The last example here is intravenous. So intravenous is you actually have the drug directly going into a vein, right? So we have a high level of concentration of the antimicrobial in your system. So that's good, right? So you can really be flooding wherever the infection is. Here's the downsides. You have to be in a hospital. You have to be admitted to the hospital. You have to be hooked up to an IV line. It gets really expensive, and you could have more severe side effects because you are basically dousing all of your bacteria with high levels of antibiotics. So you might be seeing some of those negative side effects of destroying your normal microbiota more than you would with some of the other methods. So, as a clinician, somebody who's prescribing these things, you need to take into consideration your patient, their willingness to follow directions, the severity of the infection, and the outcomes, the risk versus reward for side effects, and getting a control of the infection. So all of those have to come into play. One route that's not mentioned here, but I'll mention it, is topical. But that doesn't really get into the bloodstream, so that's why it's not on this list. But topical administration has to be for like surface infections and things. Okay. All right, so then the last topic of this mini video is kind of toxicity, side effects, allergy, allergic responses. So I just found a couple kind of gross pictures. It's always fun to put gross pictures in slides. So I think of the antifungal drug is called Flagyl. You get what's called black hairy tongue. No, you don't grow hair. It just, you get this coloration on your tongue. And then tetracycline affects the enamel on your teeth. And so it kind of turns them gray. And this is a permanent change. It is not something that goes away once you stop taking the drug. So it doesn't affect the functionality of the teeth. They just get stained, and they can't really come back unless, I guess, the person gets veneers or something. You could also have side effects like we mentioned before. So disrupting your normal microbiota. We'll talk more about that in chapter 14. But a lot of times it's digestive issues, diarrhea, vomiting, nausea, those types of things, because you have a lot of normal microbiota in your digestive tract. And if you disrupt that, it can lead to some side effects. You could also cause what are called opportunistic infections. Again, we're going to talk about that more in chapter 14. But if you are taking strong antibiotics for a respiratory infection, that could lead to opportunistic infections, yeast infections, bladder infections, diarrhea from overwhelming Clostridium difficile organisms, those types of things. So keeping that in mind, there are always that, again, risk versus reward. What do we need to take care of that could be life-threatening and live with some of those consequences of side effects? And then allergic reactions, people can be allergic to almost anything, and antimicrobials could be some of those. So a lot of times if you're filling out questionnaires, do you have any allergies to, penicillin, sulfa drugs, those types of things? It's just your body is now recognizing those as foreign. They are foreign, but they're not like a foreign pathogen that could cause disease, but your body reacts as if they are. And so that's just another thing you have to watch out for if people have sensitivities and allergies to things. Okay, so that wraps up our discussion on spectrum of action and efficacy. The last mini lesson is going to cover antibiotic resistance. So I will see you then. Bye.